Welcome dear students, this is Dr. Pratyusha and our topic for today is the anatomy of external auditory canal. As we have already learnt, the external ear consists of three parts, pinna or auricle, second part is the external auditory canal and the third part is the tympanic membrane which separates external ear from the middle ear. So in this video, let us learn about the external auditory canal and its anatomy. External auditory canal is also called as external acoustic meatus. Okay, now let us study about it in detail. External auditory canal extends from the concha of auricle to tympanic membrane. Concha is a part of the pinna which opens into the external auditory canal. So, external auditory canal is extending from the concha of the pinna or auricle till the tympanic membrane. And this external acoustic meatus develops from the first branchial cleft. And what is its length? It is 24 millimeters long. It is a canal, so it has anterior, posterior and all those directions. So 24 millimeters when measured in the posterior direction. The anterior length is slightly longer, but for all references we use 24 millimeters as the length of external auditory canal. And this external auditory canal, it is not a straight tube, it is S-shaped. So how is it directed? The outer part is directed superiorly or upwards, posteriorly or backwards, and medially. This is the direction of the outer part. And the inner part is directed inferiorly or downwards, anteriorly or forwards, and medially. This is the inner part. So this makes it look like an S-shaped canal. Now please look into this. Suppose imagine this is the external auditory canal. It is not straight like this. If I say this is the external auditory canal of my right ear. This is the outer part and this is the inner part. So outer part is directed upwards, backwards and medially. And the inner part is directed downwards, forwards and medially. So this is how it looks. Upwards, backwards and medially, downwards, forwards and medially. Now, I am stressing so much on this because when we want to examine the tympanic membrane, if you are looking from here, it cannot be seen, right? Because it is not a straight tube. So, what we try to do is we try to make this tube straight. We cannot manipulate this part. We can manipulate the auricle, which is under our control. So, we move the auricle in such a way that this tube becomes straight and we can see the tympanic membrane. So how do we move the auricle? We try to pull it laterally, backwards and downwards. Now it has become a straight tube. Yes, we try to pull it back. Once again, pull it back laterally and pull it up. So why this becomes important to us is when we are trying to examine the tympanic membrane, this shape doesn't permit us to view the tympanic membrane. So what we try to do is, we try to make this tube straight so that from here we can see the tympanic membrane. And for that, we cannot move this part. What we can do is, we can move the auricle and that will automatically move the tube. So how do we move the auricle? We pull it up, back and laterally, and now this has become a straight tube and viewing the tympanic membrane is possible. Once again, this is how it is placed now. It is upwards, this is downwards, back, front, and both are directed medially. And now what we do? We pull this laterally, backwards and upwards so that it has become a straight tube. I hope it is clear now. This is to facilitate the examination of tympanic membrane. Now let us try to understand the relationships of external auditory meatus. Superiorly, above the external auditory canal, we have middle cranial fossa. Inferiorly, there is the tympanic membrane. Inferiorly, there is the parotid gland. Anteriorly, temporomandibular joint is present. Posteriorly, mastoid air cells along with the facial nerve is present. On the lateral side, we have the auricle, and on the medial side is the tympanic membrane. I hope these relationships are understandable. Superiorly, middle cranial fossa, inferiorly parotid gland, laterally auricle, medially tympanic membrane, anteriorly temporomandibular joint, and posteriorly mastoid air cells and facial nerve. Now these relationships become important for two purposes. One is during a surgery, it is crucial that the relationships are understood. And second, during spread of infections, also these relationships come into play. Now, mastoiditis can affect the external auditory canal. It can push the external auditory canal and various things can happen. So, I hope the relations of external auditory canal are clear. Now, going further, let us study about the parts of external auditory canal. It is divided into two parts. Outer 1/3 and inner 2/3. Now, external auditory canal is 24 millimeters in size. So, outer 1/3 24/3 is 8 millimeters and inner 2/3 24 into 2/3 is 16 millimeters. This outer 1/3 is cartilaginous and inner 2/3 is bony. Which bone makes this up? It is temporal bone. That is how the S shape is formed. Outer 1/3 was the cartilaginous part and inner 2/3 is the bony part. Outer is cartilaginous 8 millimeters and inner is bony, that is made up of temporal bone, and it is 16 millimeters in size. Now let us study a little more about each one of them. First, about the cartilaginous part. For a newborn, only the cartilaginous part is present. I mean to say, the entire external auditory canal is made up of cartilage only. The bone is not yet developed. Roughly around by 3 years of age, the bony part develops. So the cartilaginous part of external auditory canal is lined by skin. It is thick skin that lines it. And this skin consists of ceruminous glands and pilosebaceous units. What are pilosebaceous units? Hair follicle along with a sebaceous gland. These are all present in the outer cartilaginous part. Because of the pilosebaceous unit, furuncles are possible in the cartilaginous part. Okay. It is lined by thick skin and the skin consists of ceruminous glands. Ceruminous glands secrete cerumen, that is colloquially called as ear wax. It's a protective secretion. And also pilosebaceous units. Hair follicles are present. Hairs can be seen only in the outer 1/3. And this cartilage is continuous with the cartilage of the auricle. As I have told you, the entire auricle is made up of a single piece of yellow elastic cartilage, and the same cartilage continues into the external auditory canal also, into the first 1/3 of the external auditory canal. Now in this cartilage, there are two deficiencies. In two places, the cartilage is not complete, and these are called as fissures of Santorini. These are transverse slits that are present on the floor. Horizontally they are present. Where cartilage is deficient, that area is devoid of cartilage, and we call them fissures of Santorini. And why is this important? Because of that deficiency, infections can pass to and from the parotid and mastoid glands and cells into the external auditory canal, vice versa. From parotid, it can come into external auditory canal, and from external auditory canal, it can go into parotid. Same with mastoid antrum. And that makes fissures of Santorini important for us. Next, let us look into the bony part. Bony part made up of temporal bone, 16 millimeters long, and the skin that is lining the bony part is thin skin. That is devoid of ceruminous glands and hair follicles. So whatever wax is coming, it is only from the outer 1/3. The bony part is devoid of ceruminous glands and hair follicles. No hairs and no wax, no ceruminous glands in the inner 2/3. That means no furuncles. When there is no hair follicle, there is no infection of that. No furuncles in the inner 2/3. Now here, at about 6 millimeters from tympanic membrane, or if I can put it in another way, 10 millimeters from the beginning of the bony part, or if I can put it in another way, 18 millimeters from the beginning of external auditory canal. 18 millimeters from that, or because the first 8 millimeters is cartilaginous part, 10 millimeters or 6 millimeters from the tympanic membrane. At this part, there is a narrowing. And that narrowing is called as isthmus. As you can see in this picture, the in between narrowing, which is 6 millimeters from the tympanic membrane, there is a narrowing, and that narrowing is called as isthmus. Now behind this narrowing, behind this isthmus, if any foreign body gets lodged, it is very difficult for that foreign body to come out because of this narrowing, and that makes isthmus important for us. Anything lodged medial to the isthmus is difficult to retrieve. Now another important point is, beyond the isthmus, there is a recess antero-inferiorly. Antero-inferiorly beyond the isthmus is a recess. What is a recess? A space. And this is important because any collections, all the debris from middle ear or accumulated wax, any secretions, they all get accumulated into that antero-inferior recess. They get pooled over there. That makes this recess important. Next, even the bony part, there is a deficiency. But this deficiency need not be present in everybody. It is usually seen in children up to the age of 4 years. But sometimes it can also be present in adults. And we call it foramen of Hashka. And why is this important? Same, it can act as a source of communication between infections in the parotid gland to the external auditory canal and vice versa. That makes this deficiency important, that is foramen of Hashka. This is about the cartilaginous part and the bony part of external auditory canal. Next, let us look into the nerve supply of external auditory canal. We have studied in detail about the nerve supply of the pinna. Although it looks complicated, it is easy to understand. Similarly, the nerve supply of external auditory canal. As I told you, it's a canal. So it has a roof, a floor, anterior part and the posterior part. Now the anterior part and roof is supplied by one nerve. The floor and the posterior wall is supplied by another nerve. Anterior wall and roof, posterior wall and floor. Let us see the nerves. Anterior wall and roof is supplied by auriculotemporal nerve. What is auriculotemporal nerve? It is a branch of the mandibular part of trigeminal nerve. If you remember, it is also supplying the pinna. It is supplying the starting part, the medial most part of the pinna. Because it is supplying the face, it just continues like that. It supplies the auricle and the temporal part and also the anterior wall and roof of the external auditory canal. Posterior wall and floor is supplied by a branch of vagus nerve. Auricular branch of vagus nerve. And this nerve has a special name. It is called as Arnold's nerve. Any eponym becomes a question for us in the exam. Arnold's nerve. Now there is another point that has to be remembered. Through the vagus nerve, the facial nerve also gives its branch through this auricular branch of vagus nerve. So the posterior wall and the floor are also supplied by a branch of facial nerve through the auricular branch of vagus nerve. Now this is very important to us because these two branches, vagus and facial nerve, have some clinical implications. Let us see. Sometimes when the external auditory canal is scratched or when it is being cleaned, which most of us must have done sometime, although it is a practice to be avoided, we put all sorts of things into the external auditory canal, hairpins, matchsticks, whatnot. So when that is done, sometimes the person starts to cough. And what is the relationship? Because vagus is the nerve that mediates cough, and it is also lining this part of the external auditory canal, and this is the connection. Vagus mediates the cough impulse, the cough reflex. And sometimes it can also cause other manifestations of the vagus nerve, such as it can lead to bradycardia, it can also cause a syncopal attack. This is about the vagus nerve. Facial nerve also has a clinical importance. If at all the facial nerve is damaged or destroyed, hypoesthesia, loss of sensations, can be felt in the posterior wall and the floor. Just a cue, one of the diseases where facial nerve is destroyed is acoustic neuroma, and in that this is a very important sign which we call as the Hitzlsperger sign. You will of course learn more about it in acoustic neuroma, but because we are in this context, I'm just explaining. Facial nerve gets damaged in acoustic neuroma, and as one of the signs of that disease, loss of sensations are seen in the posterior wall and the floor, and that loss of sensations is called as Hitzlsperger sign. Why does this happen? Because facial nerve is supplying the posterior wall and floor of the external auditory canal, and that is why it is important that we learn and understand the nerve supply of various structures. So this is all about the anatomy of external auditory canal. Let us very quickly revise everything. The external auditory canal extends from the concha of the auricle to the tympanic membrane. It develops from the first branchial cleft. It is 24 millimeters long and it is S-shaped. Now this 24 millimeters long is measured from the posterior wall, and that is used for all references. It is S-shaped. The outer part is directed superiorly, it is upwards, posteriorly, backwards and medially. The inner part is directed downwards or inferiorly, forwards or anteriorly and medially. So this is the direction of this S-shaped tube, and it is important because to examine the tympanic membrane, we need to make this tube straight by pulling the auricle. Next, if we look at the relationships of external auditory canal, superiorly middle cranial fossa, inferiorly we have the parotid gland, anteriorly we have temporomandibular joint, posteriorly mastoid air cells and facial nerve. It's important that you remember facial nerve. Laterally auricle is present and medially tympanic membrane is present. Parts of external auditory canal, two parts because it is 24 millimeters long. Outer 1/3 is 8 mm and inner 2/3 is 16 millimeters, and outer is cartilaginous, inner is bony. It is made up of the temporal bone. Cartilaginous part consists of ceruminous glands and pilosebaceous units, and the skin lining it is thick skin. It has two deficiencies which are called fissures of Santorini. Now let us quickly recap all the deficiencies that we learned so far. First is cartilaginous deficiency in the pinna. Two areas are devoid of cartilage. One is the lobule, which is just made up of the fat, no cartilage. And second is incisura terminalis, where there is no cartilage. Just a recap. And that's important because we can pierce through the incisura terminalis. And in the outer cartilaginous part, deficiency is called fissures of Santorini. And inside the bony part also there are deficiencies, not compulsory but could be present, and they are foramen of Hashka. Now it's very clear, but in an NCQ exam if you see options, by chance if you face any confusion, cartilaginous part, Santorini, C and S sound similar, sir and sir. Cartilaginous part, fissures of Santorini. Bony part, automatically it is foramen of Hashka. Okay. So the bony part is devoid of ceruminous glands, no hair follicles, and the skin lining it is thin skin. And so because there are no hair follicles, obviously furuncles are not possible in that area. And in the bony part, we have a narrowing that is called as isthmus. Anything lodged medial to the isthmus, it's difficult to retrieve that object. Foreign bodies can usually go and lodge there. And the medial to the isthmus, there is a recess called as the antero-inferior recess. It's present anteriorly and inferiorly. Obviously, only because it is inferior, something can get collected there. All the debris and secretions get collected there in any middle ear or external ear infections. And the deficiency, as I already told, is called foramen of Hashka. And the nerve supply of external auditory canal or external acoustic meatus, anterior wall and the floor is supplied by auriculotemporal nerve, which is a branch of trigeminal nerve, branch of mandibular nerve of trigeminal nerve. Posterior wall and floor are supplied by two cranial nerves. One is the vagus, whose branch is called Arnold's nerve, and the second is the facial nerve. Facial nerve also sends its fibers through the auricular branch of vagus nerve only. So I hope with this, the anatomy of external auditory canal is very clear, and with this background, we can understand the disorders affecting external auditory canal. Thank you very much.